This is my respiratory assessment for the infant with pertussis. A quick introduction to my patient is he was an 8-week-old male. He presented to the emergency department for ongoing cough and increased work of breathing. He had a confirmed diagnosis of pertussis whilst he was in ED. And following that diagnosis, he was admitted to the paediatric ward for ongoing observation and management. Health history. So health history is obtained from the infant by working close partnership with the infant's mother and any extended family. Okay, so history of the infant's current illness, pertussis. So developed a persistent cough 3 days ago. It was day 1 of severe coughing when the infant was admitted to the paediatric ward. There was vomiting post-coughing episodes. Infant was unsettled, lethargic, had decreased oral intake and urine output. Mother had also presented with a cough, but there was no GP checkups prior to admission for mother or for the infant. Prenatal and birth history. Maternal health history during pregnancy. Mother was smoking throughout, reported 8 cigarettes per day. Maternal depression. Mother not immunised against influenza, COVID or pertussis through pregnancy. Active at attending antenatal appointments, and this was her first baby. Birth history was quite unremarkable. Normal spontaneous vaginal delivery at 37 weeks. APGAR scores were above 8, so normal. Infant's birth weight and length were on the lowest side of normal, but considering just 36 weeks gestation, but infant was doing quite well, with a successful transition into extrauterine life and discharge 48 hours. Infant development and medical history. Everything was quite unremarkable other than the infant hadn't been immunised against pertussis yet, which you can give at 6 weeks, but it's generally due at 8 weeks. And since the bub was 8 weeks and with the illness, this would be delayed. So this would be something the nurses and doctors would have to follow up once baby's well enough to have that immunisation. Other than that, baby was feeding well, meeting developmental milestones. Mother denied any injuries at home. Medications, no regulars at this age, just had the vitamin K and Hep B vaccination at birth and your known allergies. For the medical and social history of the family, I'll just highlight the most important ones here. So although mum was young, unemployed, she smoked heavily, ongoing cough and running nose for 10 days as well. So mum was also sick with the same symptoms. The mother and baby lived with the maternal grandmother who was vaccinated against pertussis and didn't have any recent history of any illness. Okay, so now we'll jump into the focus respiratory assessment and findings. Okay, so I've just popped in the infant's vital signs and observations. I'll just skim over them quickly as I'll mention them later on in the slides. So temperature was normal, pulse rate tachycardic, blood pressure I didn't obtain. It was just causing the bub too much distress, and it's also not routinely done in infants as it's actually considered a late sign of deterioration. So you should be looking out for stages earlier, so the respiratory rate, work of breathing, and circulatory status, than solely interpreting the blood pressure. So saturation's 98% on 0.5 litres of oxygen. Respiratory rate was 70, which is tachypneic. Good central cap refill and FLAC of 2, just as baby was quite irritable. So additionally, IV therapy was running at full maintenance. Infant was in a cot, head on bed elevated at 40 degrees in a supine position, and mother was in attendance. Inspection. So firstly, I observed the infant without disturbing him. I assessed his respiratory system for a complete 60 seconds. Now it's quite important that you do this for infants under 6 months because they tend to have periodic breathing patterns. So it's a cluster of regular breathing with shallow breaths followed by sometimes apneic episodes, and that's just because the infant's respiratory system quite undeveloped, it's quite immature, and we call that central apnea. However, the infant's oxygen saturations remained above 95% on 0.5 litres of oxygen. Infant was tachypneic and tachycardic, so that was abnormal finding on his oximetry reading. Audible nasal congestion with nasal secretions. Infant was irritable, rubbing at his nose, did have a strong cry, however also had intercostal and subcostal recession. So that's a sign of moderate work of breathing, the infant really sucking in to get that air into the body. Pink in colour, chest was symmetrical. Spontaneous, non-productive cough was lasting for less than 30 seconds and was associated with less than 10-second apneic episodes. The infant would become flushed in the face, but once the coughing resolved, colour went back down, saturations came back up as well. Auscultation. So I used the diagram of the stethoscope to listen to the breath sounds throughout the lungs. So ensuring that the stethoscope was warm prior to placing on the infant's chest, I listened over the anterior, posterior and lateral intercostal spaces working in a Z shape, listening to both the inspiration and expiration on each location. So on my auscultation, I found fine crackles or rales heard on the left lower lobe during inspiration. There was nil other wheezes or coarse breath sounds, otherwise good air entry throughout. Palpitation. So this is feeling for any abnormalities. On palpitation, I didn't find any crepitus, pain, tenderness or growth. There was nil swollen lymph nodes, so the axillary lymph nodes and the cervical lymph nodes are changed from the chest, so they can become enlarged if any infections are there. So chest expansion was symmetric. Skin was warm and dry. Cap refill was less than 2 seconds, so that's the central cap refill in an infant. Percussion. So this is not routinely performed on infants just because their lungs are so small, but it is something we do for our older pediatric patients on the ward. It's really useful for identifying lung consolidation. So it's just a tapping motion, so you can do it posteriorly and anteriorly. So healthy lung tissue is resident, abnormal lung tissue dull and hyperresident. Key findings: tachypneic, tachycardic, nasal secretions and congested breathing, crackles left lower lobe, baby was irritable, moderate work of breathing with subcostal, intercostal recession, spontaneous coughing episodes followed by apnea, a bit of a colour change in desaturations for less than 10 sections, already on oxygen therapy 0.5. So what the things I'm thinking were progression of illness, possible pneumonia, baby is higher risk with the immature respiratory center and depressed immune system. This is deterioration. Now we will discuss the health priorities of the infant. Immediate nursing priorities can be identified by using the ABCD approach. So this highlights life-threatening conditions in sequence of priority. So in the case of the infant, following the respiratory assessment, my key nursing priorities were surrounding the infant's airway and breathing. So my main priorities were to maintain a patent airway free of obstruction, maintain adequate gas exchange. Failure to respond to respiratory distress can lead to hypoxia, secondary illness like pneumonia and acidosis. And so infants can also rapidly deteriorate. Nursing priority. So the main priority or the most immediate priority in this case was clearing the infant's airway, ensuring a patent airway and more effective breathing. So because of the excess secretions and it was audible that the infant was very congested, my main priority was clearing his nasal cavity, as infants are nasal breathers. They breathe through their nose. So I used suctioning and I also replaced the nasal prongs as they were blocked. This ensured a patent airway for the infant and his work of breathing did reduce. So that's the management of a symptom. So other management of symptoms would be supporting correct positioning, so either on his side to reduce the risk of aspiration, assisting the baby in an upright position with the support of the head So this helps during coughing episodes. It just allows that lung expansion and therefore more lung clearance, stronger cough and a more lung clearance as well. The other management is antibiotic treatment, so continue that as prescribed. Generally azithromycin for infants, so it reduces the infectious period but doesn't really alter the duration of the cough once infected. There's also the diagnostic testing to investigate those rails a bit further. So in pertussis, what happens is the toxins released by the bacteria cause inflammation and also cause the cilia to be paralyzed. So it increases the risk of pneumonia because the lungs aren't able to push out any bugs with that cilia. So chest x-ray and serology are really important. Chest x-ray is going to see if there is any consolidation in the infant's lungs. Infant comfort is also very important, so ensuring that you're clustering cares and promoting rest. Increase vital signs and remain on continuous pulse oximetry. Infants in respiratory distress are very dangerous, and infants tend to deteriorate very rapidly. So having him on that continuous pulse oximetry, especially during his coughing and apneic episodes, lets you keep an eye on those saturations and heart rate very quickly. So it's also, you would have him right near the nurse's station, and ideally you'd have him on a one-on-one or a very small patient load ratio for the nurse. Parental education, so this is surrounding infection prevention and also immunization. It's also trying to ensure compliance that the mother is taking antibiotics as well. So this is going to prevent further infections for everyone. And just your hand washing, going to be on droplet and standard precautions. So wearing a gown and gloves, ensuring correct hand washing techniques. Also letting the mother know, as she is a smoker, just to limit her smoking, or if she is to smoke, to remove her clothing, change her clothing, because the smoke on the clothes for an infant can cause a more of an inflammatory response and exacerbate his already respiratory distress.